Hello and welcome back to Unacademy. So I hope that I'm very much audible to you guys. Hello and welcome back to Unacademy. Okay, so welcome to Unacademy. Let's get NEET PG. Here's myself, Dr. Muskan Chaudhary, Unacademy Microbiology educator, and on the Plus subscription that is being provided by the Unacademy, the biggest coaching platform online that is available for you. Assess where you can assess both the live and the recorded sessions, learning from the India's topmost educator for any medical examination, competing in the live T&Ds and testing of preparation with the highly competitive quizzes, studying on the device of our choice and benefiting from the exclusive chance of watching our classes on the bigger screen, assessing up to 25,000 of the MCQs, and that too with the high yield clinical questions and the image practice and the instrument practice, where nowadays the clinical integrated questions are very much asked from the NEET PG with printed and digital notes that are being able, you will be able to assess the recorded classes anytime and anywhere. Under Icon subscription, Prep Letter and Academy has come together where we get access to clinical and integrated essential with video lecture QBanks and the rapid revision snapshot with 2021 Dream Notes with well-structured live batches of the Unacademy recorded classes, QBanks, T&Ds, and the printed digital notes. That is two of the biggest platforms are being provided at the same time. Now, under NEET PG Plus category for 24 months, that is for 2 years, it will cost us around just 1500 per month, that is 36,000, and on the 36 for 36 months it will be 1250 per month, and for 18 months it will be 1625 per month. Do use my code, that is Muskan 10, to get 10% of the discount. And on for the iconic one, for 24 months it will be 2438, that is 58,500 for 2 years, and for 36 months it will be 1875 and 2875 for 80 months. All right, so that was about the iconic and the plus subscriptions. And we do have the raise a hand feature where you get raise we can where you can raise your hand, ask your doubts, engage in the queries, that to one-on-one interaction with your educator. Up to 25,000 of the MCQs with based on latest examination pattern, including the detailed explanations. And the special class features includes the live classes, participate in the live chat, gets our doubt clear. We do the polling for the learners, respond to the polls for a better understanding of the topic, raise a hand, talk to educator in the live class, and get your doubts resolved in time. Never miss a class because you'll get the notification for the same. Do attend the lecture note, get the lecture notes downloaded and recorded sessions of the live class. Revisit the important topics anytime you feel like, and whenever your topic is not up to that mark, you think you have not prepared, you can just revisit your topics whenever you like. Or at anytime and anywhere, specifically for the students who are doing the who are into the doing hectic internships or JR shifts, and they do find it difficult to cope up with the live classes, they can watch the recorded sessions. Now, we were talking about the HIV that is belonging to the lentivirus family, and we have the HIV-1 and HIV-2. So, we'll discuss that into detail. Now, most important thing from where the question is being asked, the first point that we need to remember is, yeah, hello, be yourself. So that is the structural and the non-structural gene. In the structural gene, we have the N, GAG, and the pole gene. What we need to remember and what is being asked, that in the N gene that encode for the from the name envelope antigens, and we have GP120 and GP41. All right, GP120, that is the spike antigen, and GP41, that is the transmembrane antigen. Please remember, we have the GP41, GP120 under coded by the envelope gene. Then we have the GAG gene, that a number we need to remember, encodes for the protein 18, P18 and P24, that is the shell antigen, and the core antigen, that is the P24. Then we have the pole gene that will encodes for the P31, 51 and 66. So that is 41, 120, 41, then we have 18, then going to this sequence, that is 120, then we have 41, then we have 18, then we have the 24, which is the core, that is the innermost, then we have the 31, 51 and 66. So that was about the structural gene. Then we talk about the non-structural gene. We have the TAT, that is the trans activating gene that encodes for the protein that will involve in the transcription. Then we have the NEF, that is a negative factor gene that regulates the viral replication. Then we have the regulator gene that enhance the expression. Then we have the LTR, that is a long terminal repeat sequence that gives the promoter, enhancer, and integration signals. So we shall know the structural and the non-structural genes of the HIV, structural and gag pole, and the non one, that is a TAT, NEF, REF, and LTR. Moving next to the serotypes, we have the HIV-1 and HIV-2. Now, HIV-2 has genetic variability, it has the genetic diversity, and it is also less virulent than that of the HIV-1. Alright, and HIV-1 is divided into three groups, that is the MON, that is the M for major, O for outlier, and N for new. Talking about the epidemiology, there are around 34.2 billion, and the prevalence of HIV in India is around 0.3%. So this is what after going about the GP 120, then GP 14, then comes the 18 and the 24. 24 is the core present inside, and it is a single standard RNA virus. Talking about the most common age group. Talking about the most common age group, the majority of the AIDS is present in the sexually active age group, that is a 15 to 49. And in 15 to 49, we have further two groups, that is a 15 to 29 and 29 to that is the 49. So that is, you can remember 15 to 30 and 30 to 50. But 15 to this 30 to 50 age group is having the more AIDS prevalence than that of the 15 to 30. Children under 15 years accounts for only 23% of the total cases. Then with the subtypes A, B, and C, most common subtype is what is the subtype A. In India, we have subtype C. Subtype C is more common in the heterosexual mode, and subtype B is more common in that of the blood and the homosexual mode. Now, high prevalence state in India. In India, subtype C is common, that in the Maharashtra, Tamil Nadu, Andhra Pradesh, Nagaland, and the Manipur. Now, talking about the high prevalence states, we have seen first case of the HIV. This is important to remember. First case of HIV was seen in the 1986, where in the Chennai. Now, WHO has revised, that is ART should be started with the CD4 T cell count. So this is a prevalence that which is more common in the homosexual, that is male to male sexual transmission. Then we have 28%, that is the heterosexual. Then we have the 8%, that is injection drug abusers. Then we have the male to male sexual contact and the injection drug use combined, and then we have the others, that is less than 1%. Coming about the receptors, now receptors are again important, that CD4 molecules, all the cell expressing CD4 molecules like T helper cells, macrophage, dendritic cells, and glial cells, these are the recipient for the HIV virus that take up the HIV virus, and they are the host cell for the HIV virus, that is the CD4 molecules, and all the cells expressing the CD4, then the macrophage, dendritic cells, and the glial cells. Co-receptors, that is CXCR4, CCR5, and DC sign for dendritic cells. Both receptors and the co-receptor will bind to which molecule, that is the spike antigen, that was what 120, GP 120, spike antigen, that is GP 120. Then we have the fusion proteins, that is a GP40. If you remember, outermost was the GP120, then GP41. GP120 was the spike antigen, and GP41 was the transmembrane antigen. Both were envelope antigens, if you remember. So, what will happen first, that they will bind to GP120, and the fusion will take place with the help of the 41. HIV is a single standard RNA virus, retrovirus, and HIV RNA reverse transcriptase will help to the incorporate the proviral DNA to that of the host nucleus, and this will integrate with the host nucleus, undergo latency, and transcription and translation will take place later. Daughter virions will released by the budding. It's the same mechanism that any virus takes place, because viruses, they are totally host dependent, because they use the mechanism of the host for formation of their own daughter virions. Whenever the daughter virions will release the cell, it will always cause the lysis of that host cell, because they are released by the budding and take away the lipid membrane of the host cell. Now, so we shall discuss, yeah, hi, good morning. So we shall quickly discuss the question answers round. We basically discuss the structure of the HIV, and now we'll quickly discuss the question answers for the HIV that are being repeatedly being asked. And again, we'll take a short session for the HIV, so that we'll make a quick revision. Now, comes the first question, that is the resistance of the HIV infection occurs due to the mutation of what? That is a CCR5, CXCR4, GP41, CD4, or GP120. So resistance to HIV occurs. Now, resistance to HIV occurs in those people in which there is mutation in the receptor, co-receptor, that we've already talked about, in which they are having the mutation in the co-receptor, that is a CCR5. That is a CCR5. Now, what happens if there is a genetic mutation? If there is a genetic mutation in the CCR5, CCR5, that is known as CCR5 delta, then there are around 32 variants resulting into the this changed this host cell, which will not will result in the acceptance or binding of the virus, that is HIV. So these are the lucky people, they are having the mutation in the CCR5 and not resulting in the fusion of the virus, that is the HIV virus. Now, moving next. Causative agent of the AIDS was discovered in 1983, 1976, 1994, or 1967. So, the causative agent of AIDS was discovered in 1983. Very true. It was discovered by Sir Luke Montagnier. Montagnier and the colleagues from the Pasteur Institute, that is the Paris, and they isolated the HIV virus from a West African patient with the generalized lymphadenopathy. Just remember the year that it was diagnosed in 1983, and that was by the Sir Luc Montagnier. Now, WHO AIDS defining illness are herpes zoster, oropharyngeal candidiasis, CMV retinitis, cryptococcal meningitis, or primary brain lymphoma. So, what do you think is the defining illness for the AIDS? Now, when we talk about the defining illness of the AIDS, the herpes zoster, oropharyngeal, CMV retinitis, they all are the opportunistic infections, and they all are present in case of the HIV person. So that is, they are the defining illness for the AIDS. So which is not a non-structural gene, that is a gag and with that or the pole. Easy one. Is a non-structural gene for the HIV. Now, when we talked about the HIV, we just discussed right now about the structure of the HIV before starting the question answers. That is, we are having the structural and the non-structural gene. In the structure, we have the gag and the pole, and that is the and gag and the pole, and that is coding for the GP 120, then 41, then the gag that is encoded for 18 and 24, and the pole that is encoding for the P31, 51, and 66. Rest other LTR, TET, RAV, they all are the non-structural genes. They all are the non-structural genes. Now, in the absence of any intervention, the risk of HIV transmission for the mother to baby in pregnancy or in the labor delivery and the breastfeeding in the non-breastfeeding population is. So, what is the answer? Yes. Now, in the absence of any type of intervention or prophylactic intervention in case of the mother who is already positive and she's going to deliver or in the labor or the breastfeeding, the chances of the transmission is around 15 to 25%. So that is a 15 to 30% will be the correct answer. Now that is also ranging, that depends on whether it is a developed countries or developing countries, because in case of the developing countries, it may ranges up to 35%. In case of the developed countries, it ranges up to 25%, and for the developing, it is 35%. So we take it around 15 to 30%. That is the correct answer. Now, NEF gene in HIV is for the use for enhancing the expression of the genes or enhancing the viral replication, decreasing the viral replication, or for the maturation. So NEF gene in HIV is for what use? If you remember, this is the non-structural gene. It is a non-structural gene because structural gene हमारे पास तीन ही थे. It is a non-structural gene. If you remember the full form for the NEF gene, that is 5%. Yes, the full form for the NEFGIF was the negative. It was a negative factor that was regulating the replication. So it is not enhancing the viral replication. It is actually decreasing the viral replication, decreasing the load and down regulates. The name itself, NEF, is a negative. That is what it is, down regulating the viral replication, down regulating the viral replication. Now, what is P24? It is envelope antigen in HIV or a genome or a core antigen or a shell antigen. Pretty simple one. We had the structural genes that were ANF, GAG, and POL. So that was GP 120 in the N and 41. Here we had the P18 and P24, and that pole is 31, P51, and P66. So P24, if you remember, that is the core antigen, and it is the innermost that is present, that is the core antigen in the HIV. Now, HTLV or HIV contains an extra gene that is not there in standard retrovirus, that is GAG, POLF, and or TEX. Yes. So HTLV or HIV contains extra gene. Now in the standard retrovirus, we have three standard genes that are present. That is the N, GAG, and the pole, and these are the regulatory genes regulating the replication of the viral, that is the viral replication. But when we talk about the HTLV or the HIV, some retrovirus, that is this HTLV and or the HIV, they have the regulatory other gene as well, that is the TEX or the TAT gene, that if you remember, that was involved in the this transcription. So that is the TEX gene. The commonest mode of transmission in HIV in the descending order is vertical, homosexual, heterosexual, sexual, or the homosexual, hetero-vertical homo, or the hetero-homo vertical. So, in the descending order, we have to tell the common mode of the transmission in the HIV. So there are two different terms. That is, one is the common mode of the transmission. Another is the risk highest risk of transmission, the descending order. So both will discuss. First, let me know the answer. Yes. So what is the common mode of the transmission? Coming to the common mode of transmission, common mode of transmission of HIV. In the descending order, it is highest in the homo, followed by the hetero, and also in the hetero, that is from male to female rather than female to male. All right, that is hetero, and later followed by the blood products, and later followed by the needle stick injury, and the last one is the vertical mode. So this is the common mode of transmission, that is the homo, then hetero, then this blood products, then needle stick injury, and the last one is the vertical mode. Now talking about the risk of transmission, the risk of transmission of the HIV is highest in case of the blood transfusion. That is the blood product transfusion. Next, followed by the needle stick injury, and the last one is the sexual mode. So, the highest mode of transmission is the sexual, that is a homosexual, but the risk of transmission is highest in case of the blood transfusion. Now, coming to the next one, HIV infects most commonly CD4 helper cells, CD8 cells, macrophage, or the neutrophils. So, any cell, shall I tell the answer? Any cell bearing the CD4 antigen will be the host cell for the virus of the HIV. So any cell that is bearing the CD4 antigen will be the host virus, host for the virus. So among the option now, apart from the CD4 helper cell, we also have the monocyte and the macrophage, glia cells and the microglia cells that are also the host cell for the HIV. Then we don't have CD8 and the neutrophils, but macrophage is also one of the host of the HIV. But the most common and primarily it is CD4 helper cell. ठीक है? And other cells that are also the host is bearing the CD4 antigen. So any cell that is bearing the CD4 antigen will be the host. So that is the B lymphocytes, be it the monocyte or be it the macrophage or be it the glial or the microglial cell in the CNS. So that is any cell bearing the CD4 antigen will be the host and it is primarily CD4 T cells, helper cells and the B lymphocytes, monophage, macrophage and the glial and the microglial cells. Now coming to the next one. HIV can cross the blood-brain barrier or it is a RNA virus. It is inhibited by the 0.3% of H2O2 or it is a thermostable. So again, more than one option is correct for the PGI. So HIV can. More than one option will be correct in this one. It's not a single answer. So please comment in the option if you think what else apart from the single option, what else will be the answer. Yes. So HIV can cross the blood-brain barrier. What do you think is the answer? Now, HIV crosses the blood-brain barrier. Therefore, I have seen that the encephalopathy is a common in case of the HIV people. So this is due to the crossing of the blood-brain barrier. It is a single-stranded RNA virus that is the enveloped virus. So that is what it is a RNA virus. Very true. It is inhibited by the point 3% of the H2O2 as well as 50% of the ethanol or the isopropanol or the cresol. So that is or H2O2. So this is inhibited by it. Now next is that the thermostable. It is an enveloped virus which is what thermolabile which is what thermolabile. So it is not thermostable, it is thermolabile, which is easily inactivated at 60 degrees Celsius. So latent phase in HIV is viral replication, sequestered and lymphoid tissue infective, non-infective, or rapid decline of the CD4 count is common. What in the latent phase we see for the HIV? Again, more than one option is correct in this one. Yes, A, B, and C, all three were true in the last previous question, just not thermostable because it is an enveloped virus, which is a thermolabile virus. So remember that. Okay, so latent phase of HIV will have. Yes. Now talking about the latent phase of HIV, something interesting that we need to remember that all the people who are infected by the HIV, they will go through a clinical phase of the latency where there will be symptomless. ठीक है, there will be no symptoms that will be present, but there will be active varying degree of the viral replication. There will be viral replication, and there will be presence of the HIV antibody test positive even in the latent phase, and CD4 T cell count will decrease steadily, not at rapid decline. If there is rapid decline of CD4 count, then the person will not be in the latent phase because he will start showing the symptoms. So he will have the gradual decline. So this is not true. Now coming to the first option, viral replication is there, and also there is sequestration of the lymphoid tissue in the latent phase. So HIV is actively sequestered in the this lymphoid tissue. So this is also true. Now, talking about the infective and the non-infective, the person has the varying degree of the this viral cell replication, and the person is infective. So remember that because we do tend to think that the person is non-infective in the latent phase, but in the HIV, the person is what, infectious with positive HIV antibody test. Now, which is what is the sequence which is a retrovirus follows on entering a host cell, that RNA, DNA, RNA, RNA, DNA, DNA, RNA, or DNA, RNA, DNA. Pretty simple one. This is, we know that HIV is a single stranded RNA. So something will start from the RNA only. That is the first, the RNA, the viral RNA transcription will takes place by the enzyme, that is the reverse transcriptase, into the single stranded DNA. Now the single stranded DNA will be converted by the replication to that of the double stranded DNA, and from here again the single stranded RNA will be formed for the daughter virion. So this is how the sequence takes place. First from the RNA, single stranded DNA will be formed, and then double stranded DNA, and then single stranded RNA of the daughter virions. So that is with the help of the enzyme. What enzyme? That is the reverse transcriptase, where transcription will take place to that of the DNA, then replication to that of the double stranded DNA. True about the HIV, that not transmitted through the semen, more chances of the transmission through the LSCS, that is cesarean section, lower section than normal liver, more infectious than hepatitis B male to male. Male to female transmission is more than female to male. So which of the following you think is true? Yes, what do you think? Statement. So A or B or C or D. So what is the true statement about the HIV? Now we know that there is a transmission through the semen is sexually transmitted disease. So this is not true. More chances is cases in case of the normal label we have than to the cesarean section. More infectious than the hepatitis B. It is also not true because hepatitis B is more infectious than that of the HIV. Plus male to male female transmission, we have seen that the decreasing order, it is the homosexual, then it is the heterosexual, then it is the blood products, needle stick injury, and then the vertical mode of the transmission. All right. So when we talk about the heterosexual, their studies has been shown that there is more chances of transmission from male to female than that of the female to male. Now, coming to the next one, which of the following is true regarding the HIV? That following the needle stick injury, infectivity is reduced by nucleoside analogs. CD4 counts are the best predictors of the disease progression. Infected T cells survive for a month in an infected patient, and in latent phase, HIV has minimum replication. So, which of the following is true statement? Yes, so what do you think is the answer? Which of the following two statements are coming to each of the option first? Following the needle stick injury, infectivity is reduced by the nucleoside analogs. Now, when we talk about the post-exposure prophylaxis, it has to be started, needs to be started as soon as possible, and that too within 72 hours is the last limit. So, after the needle stick injury, the post exposure prophylaxis has to be started within 72 hours as soon as possible. If it is given after 72 hours, it is no more effective, and it is highly effective started within 72 hours. Following needle stick injury, infectivity is reduced by the administration of the nucleoside analogs and the antiretroviral drug depending upon the risk of the exposure. So we give this is the true. Now CD4 T cell counts are the best predictors. Now no, CD4 T cell counts are not the best predictors for the progression of the HIV because it is not specific. Therefore we have to go for HIV RNA, which is the best predictor for the disease progression. Then we have the infected T cells. Although the infective CD4 T cells, they die, they do not survive, but those who survive, they survive up to 43 months. Okay? They will survive up to 40 3 months, that is more than 3 years, that is the around 4 years they will survive. So this is also not true, and we've just read that in the latent phase HIV is having the varying degree of replications as well as positive antibody test. So it is quite it is having replication. It is not that we say that it is minimally replicating. No, it is highly infectious during that period as well, and it is replicating as well. So this is also false. So only statement that is true right here is A statement. Now, HIV virus contains single stranded DNA, single stranded RNA, double stranded DNA, or double stranded RNA. Pretty simple one. Yes. So HIV is actually a spherical enveloped virus, spherical enveloped virus that consisting of two identical single stranded RNA, that is positive sense. So HIV is a spherical enveloped single stranded RNA containing two identical copies. So it is a single stranded RNA virus. Now, which of the following is the HIV structure? GAG, TAD, P2500 kinase or P24? It is PJ again. So more than one option is correct. So again, more than one option is correct. So which of the following is HIV structure? So if the question would have the structural genes, then we would have gone only for the GAG and the P24 because GAG that is encoding for what? P18 and P24 antigen. And if but the question is asking what is in HIV structure, so that is also TAT because we have both the structure and the non-structural genes in the HIV. So GAG, TAT, and the P24. State with the maximum number of AIDS cases is Delhi, Kerala, or Bihar, or the Tamil Nadu. We discussed about the high prevalence state that is more than 5% of the cases, that is more than 5% of the high risk group, more than 5% of the high risk group prevalence, and more than 1% of antenatal clinic that is the having the prevalence that is more than 1% in the ANC. So we discussed about the six states, though if you remember. So which of the following is maximum with the AIDS cases? No, Bihar is not the one. We discussed about the six states that were the Maharashtra. We had the Tamil Nadu, Andhra Pradesh, if you remember. Then we had the Karnataka. Then we had the Nagaland and the Manipur. Okay? So these were the states with the maximum number of AIDS cases. That is the Maharashtra, Tamil Nadu, Andhra Pradesh, Kerala, Nagaland, and the Manipur. All right, and you can easily remember like this: either the states are in south or in the northeast. We are having the high prevalence AIDS cases. That is the Maharashtra, Tamil Nadu, Andhra Pradesh, Nagaland, and the Manipur. Now, these were the states with the maximum number of the AIDS cases. Now, question is asked that high prevalence cases among IV drug abusers. IV drug abusers. In that case, what else? Which the state will be having the high prevalence only for the IV drug abusers? If the question is asking, then it will be obviously Punjab. Obviously, we have the Punjab. Nearby Punjab, we have the Delhi. If Delhi, then how come Mumbai will be behind? And then we have the is the Manipur. Okay. Now talking about this is what the high prevalence in the IV drug abusers is the Punjab, then nearby Delhi, then Mumbai and the Manipur. Remember the highest one that is the Punjab and the Delhi. Now the high prevalence amongst the sex workers that will be Andhra Pradesh. Also, we have the Karnataka and the Maharashtra and Manipur. But remember, it is 1-1 initials so that it is easy because mostly questions are for the initial ones. So, high prevalence Maharashtra, Tamil Nadu, high prevalence IV drug abuse Punjab is very obvious. Sex workers, it is what? Andhra Pradesh. Now, the world's AIDS days 1st May, 1st December, 31st October, and 29th May. Very easy one. Yes. So the world's AIDS Day is observed on the 1st of December of every year. Okay, very important, and 1st of December. The first country in the SEAR to report the AIDS was India, Sri Lanka, Bangladesh, or the Thailand. So SEAR, that is the Southeast Asian region we are talking about. In the Asian region, amongst these countries, which was the first country where the AIDS case was seen. So, talking about the AIDS cases, now the first AIDS was seen in the US, then in the Paris, and then in the Thailand. Okay? So, third country was the Thailand, and after Thailand, we that was seen in the India, where in the 1986, in which city? That is Chennai. Okay? The first country to see was the US, and the Thailand before India. Thailand has seen the AIDS case, and after that, India in the 1986, that is in the Chennai. Highest number of AIDS cases in India occurs in the age group 1 to 14, or the this 15 to 29. Also, one thing, after US now, it was seen in the Paris, if you remember, in the Pasteur Institute, the AIDS was isolated. All right. So, isolation of the AIDS was done in the Paris Institute by Sir Luke, and it was in the Paris one, and after the in the African patient, if you remember. So, let's remember the first, and when it was seen in the India. Highest number of the AIDS cases in India occurs in the age group 1 to 14, or 15 to 29, 30 to 44, or more than 45 year of the age group. We have discussed about the age group. Sorry. So, when we talk about the AIDS prevalence, it is highest in the sexually active people, young people, that is between 15 to 49-year age group. In that, further, we have two subgroups. One is the 15 to 31 and 30 to 51. All right. So, 30 to 51 has more prevalence of around 55%. So, the age group that is best given, that is a 30 to 44. Now, coming to the next one. True about the HIV, that MTC is 25%. Semen is more infectious than vaginal discharge, infectious in the window period. Or South Africans have 72% of the total global cases, and the children infection is rare. So, which of the following is true? And multiple options will be correct in this one. MTC is mother to child transmission. So more than one option will be correct in this one. Is a PGI question. So please comment in the section which of the following statement you think is true about HIV. Yes. Now we'll come to each of state. Mother to child transmission is around 20-25%. This is true. Semen is more infectious. Yes. Male to female is more infectious rather than reverse. So that is semen is more infectious than the vaginal discharge. This is also true. Infectious, and yes, we have discussed that in clinical latency period, although the patient will have no symptom, but he will be infectious, plus he will have the positive antibody testing. South African has the highest load of the total cases over the world, that is around 70 to 75%. And children infection is rare because we have seen the age group that was 15 to 49, and two subgroups, that is 15 to 30 and 30 to 50. 30 to 50 age groups has more chances than 15 to 30, overall 15 to 49. In the children, the cases are rare and up to 3% only. So all the statements are true in this one. All right. So apart from the E, B, and A and C are also true. Common CNS lesions in the HIV is caused by the Cryptococcus, Toxoplasma, neurocysticercosis, mucormycosis, or the lymphoma. So, common CNS lesion in HIV is caused by, again, PGI, more than one option will be correct. Now, just one option will not be correct. It's a PGI one. Please read it carefully. More than one option will be correct. Yes, A is also true. Apart from A, what are the common CNS lesions that we see in the HIV? That is, we see the cryptococcus, we see the toxoplasma gondii, as well as we see what? We see the lymphoma. So A, B, and E, they are true. Fungal infection in the AIDS. Now, just a second. Fungal infection in the AIDS, that is a mucormycosis, aspergillosis, disseminated candidiasis, mucocutaneous candidiasis, or the pneumocystis cerevisiae. So, what are the fungal infections that we see? Now, when we talk about the protozoa for the HIV, then we have the common, that is the Toxoplasma gondii, we have the Isospora belli, we have the Cryptosporidium, as well as the strongyloids. When we talk about the bacteria, very obvious, that is the Mycobacterium tuberculosis and the Microbacterium avium. Intracellular infection, as well as we have the Listeria, Nocardia, Streptococcus, and the Campylobacter. Talking about the fungus, that is important fungal infections are the candida, are the candida. Apart from this, we have the cryptococcus, that is very important in opportunistic infection in case of the HIV. So we have the candida, we have the cryptococcus, we have the coccidiomycosis, we have the pneumocystic cerevisiae, penicillin, histoplasma. So amongst that, all the options that are given, the fungal infection in the AIDS we see is what the that is candidiasis we see and the pneumocystis cerevisiae. Both are opportunistic one and we easily see in that of the AIDS person, that is candida, pneumocystic cerevisiae, cryptococcus, and the histoplasma capsulatum, that are main causative opportunistic fungal infection in the HIV. Now moving to the next one. The most common organism amongst the following is the causative agent for the acute meningitis in AIDS patient is Streptococcus aguilecti or the Streptococcus pneumoniae or the Cryptococcus or the Listeria. All are the opportunistic infections in the AIDS person, but which is the most common organism that is responsible for the acute meningitis? Yes, what do you think is the answer? Now there are two age groups. One is the adults and one is the children, that is a pediatric age group. We are talking about the acute meningitis. Now, in general, the question is asking, then we will go for the Cryptococcus neoformis. That is the leading cause for the meningitis when CD4 cell counts falls below the 100 micro. Later. All right. In the children, it is the bacterial cause that is the most common. In case of the bacterial pathogen, that is the streptococcal agalacti, that is the bacterial pathogen responsible for the acute meningitis in the children age group. So, in general, the question that is asking is the cryptococcus neoformans that is responsible for the acute meningitis. Very true. That is the answer is C. Now, in patients having the HIV infections, oral ulcer is most common due to Candida, Cryptococcus, Histoplasma, or Trichophyta. Very easy one. This is also the opportunistic fungal infection. This is as well. This is as well. So all three are the opportunistic fungal infection. Oral ulcer is most commonly due to yes, in the patient having the HIV, very easy one that we are talking about the oral ulcers. Whenever the CD4 cell counts below the 300, then the oral ulcer, apatous ulcer, or oral hairy leukoplakia by the candida starting take place. Now, moving to the next one, the tissue of the origin of the Kaposi sarcoma is lymphoid, vascular, neural, or the muscular. So is nothing that is related, even he doesn't know about the AIDS, you can easily tell what is the answer for this one, the tissue of the origin of the Kaposi sarcoma. Kaposi sarcoma, that is HHV8, that is Kaposi sarcoma associated hepatitis virus, herpes viridae virus, that is HHV8, and we get to see the purple nodules mainly over the extremities, hands and the legs, but not over the palm and the soles. So that is this is the tumor that we see in the AIDS person, and this is a vascular origin tumor. What is tumors we see in the AIDS person? That is the Hodgkin's and non-Hodgkin's lymphoma. We also get to see the Burkitt's lymphoma and anogenital cancer or the cervical cancer. So Kaposi sarcoma is a vascular origin tumor. Now, an HIV patient complains of the visual disturbances. Fundal examination shows the bilateral retinal exudates and perivascular hemorrhages. Which of the following viruses are most likely responsible for the retinitis? That is HS, herpes simplex V, and the varicella zoster CMV or the EBV. Yes, what do you think is the answer? Like the patient is having the history of the bilateral retinal exudates with perivascular hemorrhage. So that is the clear history of the patient is suffering from the CMV retinitis. The patient is suffering from the CMV retinitis, where we see the bilateral, painless, progressive loss of the vision, blurring of the vision, and we see the floaters And see, in the HIV people, when the CD4 cell count is so low that it is below 50 microliter. All right. Now there is a characteristic perivascular hemorrhage. Perivascular hemorrhage. There is a characteristic perivascular hemorrhage and exudates and floaters over of retina. So we are talking about CMV retinitis. All right. Which of the following lesion associated with the HIV infection, that is hairy leukoplakia, erythroplakia, oral lichen planus, or bullous pemphigoid? Yes, what do you think is the manifestation? Now, in the HIV people, we see the oral hairy leukopenia, that is the oral manifestation that we have already discussed about. HIV infection is associated with a glandular fever-like illness, generalized lymphadenopathy, gonococcus septicemia, sinus disease, or the presenile dementia. Presenile dementia, actually, it is. So that is a PGI question. More than one option will be correct in this one. What do you think that HIV infection is associated with? Yes. So it is associated with a glandular fever-like illness, that is infectious mononucleosis-like syndrome, with generalized lymphadenopathy as well. And we also have the sinus disease and the presenile dementia. Now, presenile dementia is seen because it actually damaged the glial cell and the microglial cell. If you remember, these are also the host cell. So, directly causing the encephalopathy and the presenile dementia in case of the AIDS person. Important features of the AIDS are follicular tonsillitis, lichen planus, oral candidiasis, hairy leukoplakia, or mitotic lesion of the oral cavity. So what we tend to see? Yes, what do you think is the important feature of the AIDS? Now, important features of the AIDS we have discussed about the oral hairy leukoplakia and the oral thrush and the oral candidiasis. So, option C and D are the correct one. That disease of the cavity, that is oral thrush, oral candidiasis, oral leukoplakia, and apoptosis ulcer are very common because of the opportunistic candida infection as well as HIV and encephalopathy and protozoal infections like the cryptosporidium as well. Persistent iron AIDS is caused by the microspora, cryptosporidia, cryptococcus, isosparobelli, or the giardia lamblia. Now, the causative agents for the diarrhea, when we talk about the bacteria, it is Salmonella and the Shigella. Whatever the bacteria causing the diarrhea will be the opportunistic in case of the HIV, as well as Campylobacter, as well as the Mycobacterium avium complex. So, next we talk about is the protozoa. We have the Cryptosporidium, we have the Microsporidia, we have the Isospora belli. Next, we have the virus that is the cytomegalovirus, and as the fungus that is the histoplasma coccidioidomycosis as well as penicillosis. So these are the important causing the diarrhea. Salmonella, Shigella, Campylobacter, Mycobacterium avium complex. Then we have the viruses that is a CMV and the fungus histoplasma coccidioidomycosis, penicillosis. So that is causing the persistent diarrhea. So that is the C. Cryptococcus we have, as well as what else we have is the Giardia lamblia. Apart from that, we have seen that when we talk about the most common the Cryptococcus giardia lamblia, we also have the Sporidia, Microspora, and the Isospora belli. So it is okay to say that the all will cause the diarrhea. Now, moving to the next multifocal tumor of the vascular origin in the patient of AIDS, Kaposi sarcoma, astrocytoma, gastric carcinoma, or the primary CNS lymphoma. We have discussed about the tumor of the vascular origin that is associated with HIV person. So we have only one tumor of vascular origin which is associated with the HIV person, that is HHV8 or Kaposi sarcoma associated herpes viridae virus, that is the Kaposi sarcoma when showing the purple color nodules over the extremities. They are purple because they are vascular origin, and we tend to see that in cases of what the Kaposi sarcoma. Now, in India, most common cause of TB in HIV is tuberculosis, microbial tuberculosis, MAB, microbial avium complex intracellular, microbial bovis, or sacroflagellum. The most common cause of TB is easy one. In India, the most common cause for the TB in HIV is what? It is is even that is the Mycobacterium tuberculosis, mainly in the developing countries like the India. The most important pathogen is the Mycobacterium tuberculosis, which also multi-drug resistant. WHO stage 4 includes toxoplasma pneumocystis or the HIV wasting syndrome or the oral thrush. So it is oral thrush which belongs to the stage 3. Rest other belongs to the stage 4. Now we'll discuss the stages of the HIV once we are done with the PYQs because it's a long list. Now, major signs of the HIV case definition according to the WHO: generalized lymphadenopathy, prolonged fever for more than 1 month, or the chronic cough more than 1 month, or prolonged diarrhea for more than 1 month, or weight loss for more than 10%. So when we talk about the HIV definition criteria, we have the major criteria and the minor criteria. So we need to have at least two major criteria and one minor criteria. So what are the major criteria? That is weight loss of more than 10% or the chronic diarrhea for more than 1 month or fever more than 1 month. So diarrhea or fever more than 1 month and the weight loss for more than 10%. Then we have the minor signs. Minor signs, that is cough present more than 1 month and the generalized psoriatic dermatitis with or the herpes zoster infection or the chronic progressive disseminated herpes simplex infection or the oral candidiasis or the generalized lymphadenopathy. So we shall have two major symptoms and the one minor. In the major, remember it is weight loss or the chronic cough with the fever. Weight loss with chronic diarrhea with the fever. So that is weight loss of more than 10%, diarrhea for more than 1 month, and fever for more than also from more than 1 month. So that is the major criteria. That is what prolonged fever for 1 month. Then we have the diarrhea for more than 1 month and the weight loss that is more than 10%. So weight loss more than 10%, diarrhea and the fever for more than 1 month. True about the HIV are all except in India. Mainly it is caused by the HIV-1. Vertical transmission is the most common mode and IV drug abuse increases the risk. Paramedical workers are at high risk. So true. In India, mainly it is caused by the HIV-1, then that of the two. This is true. Now, the most common mode is not the vertical transmission, it is the sexual mode, that is the heterosexual in India, more than that of the homosexual, least is that of the vertical. IV drug abuse increases the risk, yes, and paramedical workers are highest risk. This is also true. Only B option is not true. Window period in HIV is 3 to 12 weeks, or 8 to 20 weeks, or 6 to 24 weeks, or none. So, what is the window period in HIV? Now, window period is a time when antibody detection in the this HIV is negative. So that is around 2 to 8 weeks. That is around 2 to 8 weeks. That is up to 2 months is the window period where antibody detection will be negative. So that is around 2 to 8 weeks. The best one is around 3 to 12 weeks. Mother to child transmission occurs maximum the first trimester, second perinatal, or the breastfeeding. Yes, what is the answer? Now, mother to child transmission, if there is no post this prophylaxis we are taking, intervention we are taking, then we have discussed it is around 15 to 35 in developed countries up to 25%, and in developing it is up to 35%. There are the chances of mother to child. And the risk factors are there, then we have to give the antiretroviral therapy, then we have to do the C-section and refrain from the breastfeeding. Now, the mother to transmission occurs maximum at with trimester, and the maximum transmission occurs during the delivery. During the delivery, and therefore we prefer the C-section because the maximum transfer of the HIV is during the delivery, during the vaginal normal delivery. So we prefer to do the C-section, and therefore we go for the answer that is a perinatal period with the maximum transmission occurring. All are true about the viral genome of HIV except two strands of RNA contains the DNA-dependent DNA polymerase, contains the gag polyp M, and most complex retrovirus. So all are true about the viral genome of HIV except. So it contains two strands of single stranded RNA which are identical. So this is true. It contains a structural genes at a gag pulp amylase. This is also true. It is the most complex retrovirus. That is also true. But it contains the RNA dependent DNA polymerase. If it doesn't remember, then also it's easy because we know that it is a RNA virus. Therefore, first we'll have to make from RNA to DNA. Then we'll again make the RNA, so that is a RNA dependent DNA polymerase. So that is the contains the RNA dependent DNA polymerase, not DNA dependent DNA polymerase. Now moving to the next one, plan 3 by 5 in HIV means treating at least 3 out of 5 AIDS patients, providing treatment of 3 million sufferers by the 2005, diagnosis of at least 3 out of 5 AIDS or all of the above. This is actually 3 by 5 initiative, although it is old now, that was used before. In this, what we used to do, we used to provide the antiretroviral therapy, and to what? It was supposed to achieve by 2007 and was achieved. So this question will rarely come now because it's an old question that is providing 3 million ART treatment to 3 million sufferers by 2005, which was achieved by 2007. The first case of HIV was reported in 1981, 84, 86, or 88. Yes. If you remember, the first case was reported in US, isolated in the Paris. Then the third country was the Thailand, and later was the India, in which was the 1986, and where it was seen in the Chennai. But the first case was seen in the US, and in which year? It was 1981. 1981. Most common opportunistic infection in HIV positive patient is MTB, Cryptococcus candida, cryptosporidiosis. What do you think is the answer? Yes. What is the most common when we talk about the most common opportunistic infection in HIV patient in India? It is TB. But when we talk about the world or the developed countries, is this pneumocystic Aerovisi. Yeah. So most common opportunistic infection in India is a TB and the pneumocystic aerovisi. That is the most common opportunistic infection present in the world as was pneumocystic aerovisi. In India, it is the MTB. So I will end the session here. Thank you so much. We still have that is around 10 questions left for the laboratory diagnosis of HIV that we'll do in the next session. We did around 44 and around 7 to 8 questions are left as well. That is about the laboratory diagnosis. We'll do that. Now, thank you so much, and I will see you in the next session. And please do use my code that is Muskan10 to get 10% of the discount at 9:30 p.m. today. I am having the special class in which we are talking about the virology. And we'll do the virology marathon. For that, we'll do the PYQs only because that is more beneficial. I know that. And please do use my code Muskan10 to enroll into the special class at 9:30 p.m. So I will see you there. And until that, take care. Bye bye. And do like, share, and subscribe. I hope that PYQ session for the HIV was useful for you guys. And we'll do the laboratory diagnosis that are still left because it's already 1 hour 20 minutes we are doing the session. So it becomes quite boring to do the, and it is not that effective because we tend to lose that interest. The same time we read for more than 1 hour. So we'll do the laboratory diagnosis and we'll easily do the PYQs because our main pattern of study is the doing the question answers. Then we'll do the theory part of the HIV. So I'll see you soon. Take care. Until that, bye bye. And thank you so much. I hope I have not wasted much of your time in doing the random stuffs. So take care and bye bye.